so far in our show today, we've been focused on a lot of what we can do on our own. And I don't know about you, but I'm already thinking of things I need to work on right now. So I'm taking my notes. But now what we're going to do is we're going to shift gears, because one thing Dr. St. Gore was saying recently is that we all have cardiovascular disease to some degree. And that, when he said that, it scared me a little bit. Fred, I don't know, I didn't sleep too well. No, anyway. No, but it helped me to take it seriously. So people in their 30s and 40s, you have cardiovascular disease, and we need to sometimes have doctors help us with that. And so what we're so grateful to have is looking at risk factor modification and diagnostics and basically cardiology 101 here. And we have our experts, Dr. Ahmad, Ermakov, and Wang. And these doctors, they do the full spectrum of cardiology. So they're in the clinics. When the patient has to go to the emergency room, these are the doctors that get called. They're the ones visiting patients in the hospital. They're doing procedures, so they know it all. I don't want to build it up too much for you guys, but anyway, we got the experts here with us, and we're grateful to be able to hear from them and hear some stories.
Thanks, Josh. So we heard a lot about lifestyle. We heard a lot about what you can do in your life to prevent heart disease, but yes, that doesn't prevent all episodes of heart disease. So what can we do in terms of medications, and what can we do with testing to figure out, who needs to be watched a little closer? What else do we do with medications to prevent having a heart attack? So what we're going to talk about is a couple patient scenarios that are really common, patients who come to us in our office, and how we would treat these patients and what we would recommend. So the first one is a 48-year-old woman who comes to our office requesting cardiac evaluation. She has a family history of heart disease, with her father having his first heart attack at age 54. She eats a plant-based diet and exercises 4 times a week. She has no current symptoms, but she wants to know what she can do to maximize her risk factors and prevent a heart attack, and what else, what other medications and testing she needs. So my question is for Simon. How would you summarize this patient? These are her vital signs, her blood work, and how would you summarize her, and what would you recommend that we do next for her?
Yeah. So thank you so much, Robbie, and it's a huge pleasure to be here for all of you guys. So this is a typical patient that we see in our office, and in general, when I see patients like this, I like to think about what factors do they have in their life that are protecting them from heart disease, and then what factors do they have that are putting them at higher risk. So when I look at this patient, the factors that are favorable are the fact that she's relatively young. She's 48 years old. She's a woman who in general tend to develop heart disease later on in life. She does a great job with lifestyle. Seems like she's exercising regularly. She's eating a plant-based diet. And her BMI is in a healthy range. The things that give me pause, however, are the fact that she has a strong family history of premature heart disease. Her father had a heart attack before the age of 55. Her blood pressure is a bit elevated, as is her A1C, which is basically a marker of her average blood sugar, which gives us a sense of whether or not she has insulin resistance. And then looking at her lipid panel, her total cholesterol is elevated, but her HDL, which is considered to be a protective factor, is also high, which factors into that. However, her LDL is also high, and this correlates linearly with the risk of cardiovascular disease. So I definitely want to understand that a little bit better. And then her triglycerides are not dramatically elevated, but are also a little bit higher than I'd like them to be, which would be less than 100 or so. Other factors that are not part of the vignette that we could ask her about would be, is she has any history of inflammatory conditions? Does she have kidney disease? Her being a woman, if she's experienced early menopause, so less than age 40, or if she had pregnancies, if she experienced any preeclampsia during those pregnancies. Those are women-specific risk factors. And then the other thing I'd like to know is her ethnicity. If she's of a high-risk ethnicity like South Asian, that would be a extra risk factor. So beyond kind of asking about those little extra questions, I definitely want to do more testing to see, to better characterize her risk.
Great. So Simon mentioned some more testing. Cindy, what other testing would you recommend for this patient, sort of right off the bat?
Yeah, so one thing we can consider is doing an advanced lipid panel, which is further details about her lipid profile. These include, for example, large or small particle sizes for the different lipids. The other thing is apolipoprotein B and lipoprotein A, which are risk factors that we know for patients having a higher risk of MI or stroke. And then high sensitivity CRP, which is a marker of inflammation in patients as well. That's more generalized, but some of these can help us differentiate this 48-year-old woman from another similar patient. I think very commonly now we'll also use calcium scoring, which is a type of imaging to look and see if she has any evidence of early atherosclerosis. So if you look at this slide, if we can kind of look on the right-sided picture first, there is kind of a spectrum of disease. So, right, when you're born, you have very nice, quote-unquote, clean arteries as visualized in the top picture. And there's a kind of progression of disease that happens over time. We do develop plaque very early in our lifetimes, as soon as even our teenage years. And there's first, a buildup of atherosclerosis or plaque in the artery. This is worsened if you have a high LDL or have other risk factors. There's a process of inflammation that happens in the blood vessel. And there are different types of plaque that we'll allude to. Some of these plaques, the analogy I like to give my patients is that some are benign. Some are more like hills. They're small, they're flat. Other ones are scary, like they're volcano in nature. They have a very thin top and they're very likely to open up. Those are the ones that cause heart attacks. So we have a range of these types of plaques throughout our artery. So when we do a calcium score, the image that you see on the left, we're trying to see and kind of image how much plaque do you have, because we believe the more atherosclerotic plaque you have, then the higher the calcium will be inside the artery. So for example, in the top left image, the calcium score is 0, which means that there's essentially no evidence of early atherosclerosis. To make things complicated, that doesn't mean that there's no plaque, but at least this gives us some idea of where the patient's at. And then there's a progression of images that we just showed that there's progressively more calcification. So in the image to the right, the calcium score is 29, and you can see that there's this little dot of white coloring, like in the distribution of what's called the left anterior descending artery. It looks very similar in color to bone, which these are all basically calcific plaque. Well, her spine is her bone, but and then after that, we have a calcium score of 250. And then the worst one here is the calcium score of 1200. And you can see at a calcium score of 1200 that you can almost see the entire blood vessel highlighted in white. It's almost like, sometimes we call it a train track sign, that you can see the blood vessel clearly delineated here.
So Cindy, you mentioned that calcium scores can be indicative of plaque, but that score of 1200, for instance, does that mean that this patient has a blockage and that they need to have, they need to go and have an angiogram, or what does that mean? And how do you explain that to your patients?
Yeah, and that's a complicated topic, but just because your calcium score is high doesn't always, it means very likely you have coronary artery disease. But it doesn't always mean that there's a significant blockage. What we mean by significant is something over 70% blocked up. And that's very hard to visualize, especially when you have a very high high calcium score, high calcification burden. In many of my patients, though, because I know that similar to the picture on the right, the higher the calcium score, the higher the amount of plaque, then I do tend to be more aggressive with them. I do tend to stress test them more often, just to make sure that there's no obstructive disease. In some cases, if they have symptoms, it's not clear, so I will have to do more than that.
Okay. Now, Simon, what medications would you recommend for someone like our patient? Let's say she has the calcium score of 250, that's in the bottom left corner.
Yeah, so for her, the calcium score is definitely elevated and does place her at a higher risk for cardiovascular disease and, the adverse outcomes that we all worry about. So I definitely would want to start her in therapy at this point, especially because her lipid profile does show that her LDL is elevated. And so the most common medicine that you guys all hear about is called a statin. And so the way statins work is they basically inhibit cholesterol synthesis by inhibiting cholesterol synthesis, and by that they basically increase the amount of LDL receptors that are expressed on cells, and the LDL receptors basically suck out the LDL from the bloodstream and therefore kind of slow down the process of plaque deposition. Statins also have other effects that are less poorly understood, but are thought to be anti-inflammatory, and in general work to stabilize the vulnerable plaques that Cindy alluded to, the ones that are more likely to cause heart attacks. And so statins don't suck away plaque like a vacuum cleaner, but they definitely create a lower risk situation, and in general are thought to decrease the risk of cardiovascular disease by about 20 to 30%, which is a big deal.
One of the other questions that I get asked a lot in my clinic is, if someone's HDL is high, does that really mean that they need a statin? Because their HDL is high, their LDL may be a little high, but their ratio is okay. So can you address that, Cindy?
Yeah. So in this case, I think her HDL was 79, and we know that that's a good prognostic factor for her in the long term. HDL is correlated with exercise, so the more you exercise, you can increase your HDL, your good cholesterol. We know a lot of our patients have low HDLs, and unfortunately that's genetically driven, that they're just kind of born with a HDL that's very resistant to being elevated. In her case, if we actually look at her profile and look at the percentiles she falls in, at a calcium score of 250, even though she's 48, she's probably in the top 5% or 10% of women her age. So she's pretty much the highest risk for her age group. So in this case, I would say, yes, you have a good HDL, but that unfortunately doesn't completely negate your risk. And I'd probably encourage her to take a statin so that her LDL can be lower, and we can get those good other properties of statins to start working at an earlier age.
And one of the other things that a lot of times comes up, especially in someone like this who's doing everything right with her lifestyle, she's following the plant-based diet, she's exercising, is why does she have so much plaque? What her cholesterol's not that bad. So what would you say to that, Simon? Why does she have so much plaque?
Yeah, I mean, I think the process of development of atherosclerosis is so complex. There's so many variables that go into it, and like we were mentioning in the introduction, she does have some, other risk factors that could be playing a role. And, all in general, genetics is a huge component to this. And with her family history, it definitely could be playing a big role here.
Yeah, what I always tell my patients is, I can't change your genetics that you're born with, but I can change your LDL. So let me try and change your LDL. That's right. So Cindy, what about side effects of statins? Statins get a really bad reputation for things like causing dementia, diabetes, muscle weakness. So can you address that and how you talk to your patients about statins?
Yeah, that's definitely, I think, one of the big fears that patients have is starting a statin. I think maybe I'm a little bit biased, but statins are one of the wonder drugs of our era, along with antibiotics and certain types of chemotherapy. We've heard a lot of, you've probably heard of a lot of bad side effects of statins. The number one probably being myalgia or muscle pain or joint pain. Also, a lot of concerns about the progression to diabetes, and then also dementia as well. And I would say in terms of muscle pain, I would say a very common side effect, but I would say each person tolerates a statin very differently, and so just whatever happens to your neighbor or your friend won't necessarily happen to you. We also try very hard to work with our patients on what statin works for them, and certain times, like with easy switches from one to another, we're able to have people do really well. And I have some patients who take a statin like 3 times a week or a few times a week, and that seems to work fine for them. In terms of dementia, I think there have been no studies that have established that there is a definite link between the two. Certainly, a lot of people are on statins. And the other thing is that there's not, direct causation that we see, but of course, when a lot of people take medications, then a lot of other associations may be seen between the conditions. And then for diabetes, I would really say that the risk is mostly that if you have glucose intolerance to begin with, like prediabetes, that it can possibly raise your A1C or your glucose in the process, but that I think rarely does it ever fully progress to diabetes. It hasn't been kind of clinically significant overall. I've had some patients that were very worried about that, and I kept, kind of proved to them with their A1Cs and changing their doses that that wasn't totally true, and I've actually managed to convince a few people that way. So.
And I think, there are actually some studies looking at whether statins truly are causing some of the myalgias, and there's a big correlation between just the idea of being on a statin and people have side effects, and just it's sort of the placebo effect that people are looking for side effects when they know a medication causes it. So there's some studies looking directly at that. So Simon, what if someone can't take a statin? They've tried a dose, they've done everything, they've been on the 3 times a week, and they just cannot tolerate it.
Yeah, so we definitely have all sorts of different alternatives and additional medications that we can use. Sometimes we use it in addition to statins. So in general, as Cindy was alluding to, we really try hard to get people on a statin because they are so beneficial and they are so protective. But some people just have, really bad side effects and really can't tolerate it, or are just not hitting the targets that we want in terms of the LDL lowering, and they do need other therapies. So fortunately, there have been a lot of advances over the years and a lot of good medications that are on the market now. So just to name a few, there's a medication called ezetimibe or Zetia that reduces the absorption of cholesterol from the gut, and that can be used as an adjunct to a statin or as an alternative to patients who cannot tolerate a statin. It's a little bit less of a potent version of a medication, so we rarely use it alone, but a lot of times we use it in addition to other medicines. There's also a new kid on the block called bempedoic acid you may have heard of. So it's basically a medication that works in the same pathway as a statin, but it's actually a prodrug, so it has to be metabolized by the liver before it's active, and therefore it really only affects the liver cells. And because of that, it doesn't have any of the muscle side effects that statins can be associated with. So in people who do have those muscle side effects, this is a good option. And then there's a series of medications that are very potent at lowering LDL called PCSK9 inhibitors. These are injectable medicines that are injected either every 2 weeks or every 1 month, and they dramatically lower the LDL. So in patients who are at really high risk, who've had heart attacks, who've had strokes, and really cannot tolerate a statin, this is a great option. Sometimes we do use them in primary prevention as well for really high-risk patients. And then there's one more medicine that works in a similar fashion to the PCSK9 inhibitors, but it's actually injected in a clinic every 6 months. So you can imagine coming in basically just twice a year for an injection that lowers your LDL dramatically. So a lot of great medications out there.
Yeah, so I think the key is that, if one doesn't work for you, there are a lot of other therapies that we can use, and we should really go be aggressive about treating our cholesterol. And so the last question I had in this scenario is, what about aspirin? Would you put this patient on an aspirin? And we hear a lot about the bleeding risk and that no one needs to be on aspirin anymore. So what's the recommendation for aspirin?
Yeah, so as some of you may know, a few years ago, the USPSTF kind of updated their guidelines about preventative aspirin. And we used to kind of just say, okay, let's give everyone an aspirin. But we realized that a lot of patients were bleeding unnecessarily because of it in order to prevent like one heart attack from happening. As a result, a lot of younger people like this patient would, we would advise not to be on an aspirin. One way that I use to kind of make this decision with patients is that we have our calcium score, and there's actually a database of calcium scores, and it's called the MESA cohort, with a lot of patients' demographics, and then also with their calcium scores. And you can plug in all your information. If you have your calcium score, you could do that at home. You can easily look it up. And then the MESA score basically tells us, if we incorporate all the information that we have here and her calcium score, what's her 10-year risk of having a heart attack? And if that score comes out to over 7.5%, then I'll usually counsel the patient to take an aspirin. Some of us also traditionally use the ASCVD risk calculator, which does a kind of similar calculation without the calcium score, as a way to kind of figure out who's high risk and who isn't. That's kind of the way that I usually make my decision about it.
Great. Okay. So we're going to move on to our second scenario. This one's a little bit different. This is a 54-year-old man with hypertension. He's on medication. He has hyperlipidemia. He does take a statin. He has diet-controlled diabetes. And he comes in also looking for some advice on his cardiac risk. He has a family history of heart disease. He tries to walk pretty regularly. And recently he's noticed that he gets some shortness of breath when he walks up hills. He gets some mild chest tightness. And when he rests or goes to a flat surface, it gets better. So, Cindy, how would you assess this patient? His vitals and blood work are at the bottom. And sort of what would you summarize this patient? What would you tell him?
Yeah, so off the bat, this patient is a little bit older. He's also a man, which unfortunately immediately places him into intermediate risk. He also does have diabetes, which we know is a strong risk factor for coronary disease, or we call it, in some cases, an anginal equivalent. We almost assume sometimes you're very likely to have it. He's not as active as the first woman, and in addition, he has some clear symptoms that he's noticing, and some of them I would say are very concerning for obstructive coronary disease. He has the chest tightness and it's exertional. In terms of his profile, he is overweight. His blood pressure seems to be appropriately controlled. His A1C certainly is, I think, controlled for a diabetic. In terms of his cholesterol, his total is 154, LDL is 106, HDL 36, and triglycerides are 187. HDL is low for a man, it's 36, and then his triglycerides are 187. Normal would be 150 and below, so he has slightly elevated triglycerides. And certainly his LDL, while it's not bad, for his profile is probably not low enough.
So, Simon, what other tests would you order for this patient?
Yeah, so as Cindy was alluding to, this patient is quite different than the first patient we discussed, where we were really talking about someone who's asymptomatic. They didn't have any symptoms. They're really just trying to get a sense of where do I stand, what is my risk for heart disease over my lifetime. This patient's very different. I'm much more worried about him because he's actually having symptoms when he's exercising. So the testing I would not do a calcium score in this situation. What I would do is I would actually refer him for a stress test. And so with a stress test, what we're really trying to get at is we're trying to understand what are his symptoms due to. So we're assuming that if he has coronary disease, then he probably has a blockage in one of the heart arteries that is probably causing his symptoms. And so with stress testing, we're really trying to understand, is there other evidence of this phenomenon happening? So with stress testing, we try to basically provide a stressor on the heart, so that's either exercise or pharmacology, so some medication that we inject. And then we try to image the heart in different ways. So we assess, whether the patient's actually having symptoms during the time of the stress test. We can use electrocardiogram to see if there's any electrical signals that suggest that the heart's not getting enough blood flow with activity. And then we also have imaging modalities that we use. So the common ones are echocardiogram, which is an ultrasound of the heart, where we're actually looking at the walls of the heart as they contract. And then the second one is a nuclear medicine stress test, where we inject a radioisotope and are looking at the redistribution of blood flow in the heart muscle. And so by combining those two, we look at the pictures and various ways that we're assessing before exercise, and then during exercise and after. And then for example, if we're doing a stress echocardiogram, what we would see is if there truly is a decreased blood flow to a portion of the heart, there may be normal contractility or contraction of the heart at rest. However, after exercise, if a portion of the heart is deprived of blood flow, then that wall would not be contracting as well. It would be stunned, or sometimes if it's a really serious condition, the whole heart function will be decreased. So those are some of the things we're looking for. And on the nuclear imaging, we're really looking for areas of the heart that are not getting blood flow as the person is exercising. So stress testing is great. It's not perfect. So there definitely can be false negatives and false positives. So it's very important that this is, the test is appropriate for the clinical context, and that also it's interpreted by someone who has a lot of experience and is looking at multiple aspects of the stress test, not just one finding.
Right. So getting back to our patient scenario, he undergoes a nuclear stress test, And it shows a defect in the inferior wall. There is some diaphragmatic attenuation. So to explain what that is, the diaphragm sits right under the heart. So sometimes you can get a little shadow in that area just from the diaphragm. In women, sometimes you have another area from breast attenuation. And so our patient has a little bit of a difference between the rest and stress imaging in the inferior wall, the bottom part of the heart, but there is some diaphragm. So it's kind of equivocal. So Cindy, what would you recommend for this patient?
Yeah, so I guess when we say equivocal, we mean that, I guess it can mean two different things. One is that this could be a true finding where a portion, specifically the blood vessel that feeds the inferior wall, is blocked up. That's one possibility. The second possibility is, like Rabia mentioned, that this could be an artifact or a false finding, or what we call false positive. And like Simon said, these tests aren't perfect. The image that we've shown here is of a totally normal blood flow in the heart. It has a very nice kind of donut shape to it, no matter how we slice it. In this patient that we're discussing, the bottom portion of the heart is not lighting up. So in this case, I think because of his symptoms and because of his risk profile, I don't think I'd be satisfied with that answer because I'm not really able to tell the patient exactly what's going on. So I'd probably consider additional testing. And an easy way, I think, to go with this is that we could do something called a coronary CTA. A coronary CTA is similar to a calcium score. It's a CT scan. But it's a higher dose one, and we do more imaging of the heart. What we're essentially doing is trying to create a map of the arteries, and we have some images to demonstrate that. On the left is a normal coronary CT angiogram. There's a 3D reconstructed image in picture A, but the helpful pictures are B, C, D, and E, where essentially we can look at the mapping of the arteries. You can see, like in picture C, that's the left anterior descending artery, the main artery of the heart. And you can see, like, throughout that it's very uniform. There's no kind of, how should we say, like lumps and bumps. There's no black areas. Essentially, there's no blockages in this. So this is a very normal study for a patient. On the right-hand side, that's an image of an actual blocked area in picture A, and that's the right coronary artery, and we can see that in the middle of the blood vessel, it's very narrow. And then in addition, you see once again those kind of spots or flecks of calcification, and that goes with that process of atherosclerosis. In addition, we do have newer technology to look and see, because we can tell it looks narrow by eyeball, but we would like to use additional information to confirm. And so we actually have technology called heart flow, which does what's called a measurement for CT, it's called FFR. And essentially we're measuring the flow dynamics through the vessel to see, is this an actually significant blockage? And we had mentioned, significant to us means over 70% blocked up. So if you have a FFR that's less than 0.8, that would be considered abnormal. In this image, the patient's FFR is 0.69, so it's abnormal, and you can see the rest of the blood vessel is red. And then if you have a FFR over 0.8, then that would be a normal FFR. To mention, of course, like we said, stress tests and CTAs are not perfect. There are some limitations that are possible. One is that when you do a CTA, your heart rate has to be extremely low. So usually in the 50s when you do it. And so most of us will have to pre-medicate our patients with beta blockers or calcium channel blockers. And then if you have any sort of arrhythmia, meaning atrial fibrillation or extra beats, then that can cause disruption in the image because we're trying to image a moving structure, but trying to slow it down so that we can keep it still and take pictures. So sometimes those can be limitations. Also, we had mentioned if you have a very high calcium score, if that whole blood vessel looks bright white, we can't see inside the blood vessel. So there definitely are some limitations to the test as well.
So let's say our patient is the image on the right. So we see that blockage in the right coronary with a abnormal FFR score. So what would you do next for that patient?
Yeah, so this highly suggests that the symptoms that he was experiencing are due to a decreased blood flow to the heart, probably because of this blockage in the right coronary artery. Assuming he's on good background medical therapy and he's still having breakthrough symptoms, then the next step would be an invasive test. This would be a coronary angiogram. And this is done in the hospital. So the reason we do stress testing and the coronary CTA and all those things is because we want to save people from the risk associated with invasive testing. However, in this situation, we really want to help the patient, and so we feel that the benefits of the procedure are outweigh the risks. And so what happens with an angiogram is a patient comes to the hospital, we give them light sedation. Generally, people are kind of in a twilight state, maybe somewhat awake, and then we get access with a needle to an artery either in the wrist or in the groin, and we thread a long catheter all the way to the heart. And then we inject dye, contrast dye, similar to the coronary CTA, into each of the major heart arteries. And then we see whether or not there's a blockage. And the difference between this test and the coronary CTA is that we're actually inside the blood vessels and we can actually intervene and fix the blockage. And we do that by putting little wires inside the heart arteries and then a balloon. And on the balloon, usually there's a stent. A stent is a little expandable wire mesh that stays inside the blood vessel and pushes the plaque onto aside and restores blood flow to that blood vessel. Generally, after a stent is placed, patients need to be on blood thinners because the body wants to react against it and form blood clots. So if you're not on blood thinners, it can turn a bad situation into an even worse situation. So it's very important to take those medications. But over time, the stent becomes covered with a layer of cells and basically becomes part of the architecture of that vessel. And the medications can be adjusted after some time. The fact that this is an invasive procedure does mean that there are some risks, but this has been around for a long time, and in capable hands, the risks are very, very small. I would say on the order of about 1%. The things that we always discuss are bleeding at the site we enter the body, so either the wrist or the groin, damage to the blood vessels, a small chance of stroke if there's a blood clot that forms on one of our catheters and breaks off and goes to the brain, small chance of injury to the kidneys from the dye that we use, and then very rare catastrophic consequences, heart attacks, death, those kind of things, but very, very rare.
So how does this patient prevent another blockage from forming? He had a stent done, his symptoms are better, he feels great, but what does he do to prevent this from happening again?
Yeah, so we didn't talk about his other blood vessels in this case, but very likely if he has one process happening in his right coronary artery, he has very likely plaque in the other arteries. The things that we can do, we kind of talked about in the first case, we'd like his LDL to be extremely well controlled. In this case, we'd probably bring his LDL down to 55 to about 70. I think American guidelines, we're still saying like less than 70, but some of the European guidelines are saying we should bring things down to 55. So that's one thing we can definitely work on for his LDL. In addition, there are certain ways, I think, for him to increase his HDL. He can do that a little bit through medications and then also through increasing his cardiovascular fitness. For most patients that get a stent or for other patients that have heart attacks or open heart surgery, we usually encourage our patients to go to cardiac rehab. That allows them to get more education about lifestyle and eating, and then also know how much exercise they should be doing and when it's appropriate to kind of increase overall. And probably one other idea is that he could work on his diabetes and see if he can bring his A1C down any further.
So I've heard of some of these new medications for diabetes. What are these new medications and how do they help the heart? What medications would you recommend for him, Simon?
Yeah, so you guys have probably heard over the we call them new medicines. Honestly, they've been around for quite a while, but the reason they've been in the press a lot more is that's because we have outcome trials now looking at patients with cardiovascular disease, and these are some of the first anti-diabetic agents that have really shown great benefit in patients with cardiovascular disease. So some of the names are basically two classes. There's the GLP-1 receptor agonists, which are like, Ozempic, semaglutide, and that type of medicine, which is an injectable. That's also been associated with great weight loss. And so I think that a lot of people are hearing these names in the lay press. The second class is called the SGLT2 inhibitors, and the names are basically Farxiga or Jardiance, empagliflozin or dapagliflozin, and they've also been shown to have great cardiovascular benefits. The types of conditions that have been kind of improved with these medicines are a little bit different. So the GLP-1 receptor agonists tend to improve a little bit more on the atherosclerotic cardiovascular disease side. So patients with ischemic stroke or coronary disease tend to do a little bit better with those medicines. The other class, the SGLT2 inhibitors, are geared a little bit more towards patients with kidney disease or heart failure. And we've even have trials that show that patients without diabetes still benefit with these medications. So don't be surprised if you have one of these conditions and your doctor starts offering you diabetes medicines, even if you don't have diabetes.
So one last question I have before we go to the audience is there such thing as too low in LDL? Is it dangerous to have your LDL too low?
No.
No.
Yeah.
No, I honestly, I do feel that, and I think the studies have borne this out, is the lower the better, the earlier you get it down, the better. The longer your body's exposed to low levels of LDL, the better. I mean, some of these medicines that I alluded to, the PCSK9 inhibitors, the way they were discovered is they looked at people who have a gene mutation within this PCSK9 protein, and they have inherently super, super low LDL levels, sometimes in the single digits. And these patients have very low levels of cardiovascular disease over a lifetime. Some people get nervous with those numbers because they're really low, and we know that we need cholesterol in our body. But, you know, the things that we worry about, dementia, susceptibility for brain bleeding, things like that, have not been borne out. So honestly, I don't think that there's really a floor to LDL.
So I think we're ready for some questions from the audience. We'll get some, get the microphone.
I can just ask a question.
No, we need a microphone. Yeah, we'll wait for the microphone. Right here.
Would a coronary calcium score be of any diagnostic value for a patient that's already had an MI?
So the question is, would a coronary calcium score have any diagnostic value for someone who's already had an MI, has coronary disease? A heart attack.
Yeah, heart
Sorry.
attack. I would say very, very unlikely to be helpful because you know that the calcium score is going to be high in that situation. I had some patients who say, oh, I want to check my calcium score every year. But it's really not helpful in a way. I would say the only time it's helpful to repeat a calcium score is if you're 0, and then you wait maybe 5 or 10 years and you repeat it again. But all it's going to give you is a number, and I don't know that that number is really helpful to tell you much that is already known about the patient.
Yeah, I think the role of calcium score is really for looking at those people who don't already have that diagnosis and seeing how aggressive they need to be. For someone who's already had a heart attack, hopefully we're already being as aggressive as we ever will be. Let's take this one.
How long the stents last, effectively? I know they can be there a long time, but how effective, how long? Talking about 10 years?
So the question is, how long do stents last?
Yeah, I think that's a great question. Just like with medications, there's been a lot of development in the stent space. And so we're on multiple generations of these newer stents. So there's multiple types of stents. The first generation was called bare metal, which is literally just metal. The newer generation of drug or stents that have been used over the last many, many years are drug-eluting stents. So they're not simple. They actually exude a little chemical that prevents narrowing of that stent over time. And so these stents are lasting for a really, really long time. But every patient's different, and it really depends on the interplay between that stent and their heart disease that they already have, plus the other comorbidities that they have. If they're on dialysis, if they have diabetes, all those things, all of that impacts the duration of a stent. But there's no reason why a stent can't last your whole life.
Take this question up front.
For working on diabetes, if you have that tendency, you mentioned some pretty aggressive medications. What are the other kinds of options, diet, lifestyle, other things that could be important in that scenario?
So the question is, for diabetes, what are some other options for managing diabetes other than the medications we mentioned?
Okay. Yeah. So I think, we generally counsel our patients about lifestyle, and that's, the mainstay for all of this is a foundation. On top of that, diet and exercise is what we talk about. For diabetes specifically, it's really carbohydrate control, avoidance of sugars. But in addition to that, we do have other medications. So, the ones that I mentioned are starting to become more used up front, but we do have, for patients who are kind of on the borderline or don't have other manifestations of diabetes, we do have other agents that are a little bit softer and a little bit more gentler, and actually do likely have other benefits in terms of longevity, potentially even, like metformin is usually a starting medication for diabetes. But it really is a combination between aggressive lifestyle modification and then some pharmacotherapy. And, like I said, these medications that are coming out are really beneficial, and they're not super potent, I would say. So in patients who have advanced diabetes, they still may need insulin, but this is a good middle ground that also provides other protection.
We're going to go to an online question real quick.
So we have had a lot of questions asking about supplements. I'll give you the list. Fish oil, CoQ10, fibrates, MCT oil, coconut oil, vitamin K, and apple vinegar. Is that enough?
Yeah, so I think the answer to that, this is what I usually tell my patients, is that the recommendations we give as physicians come from evidence that we've gained as scientists as well. And unfortunately, not a lot of trials have been, well, one is they haven't been done on these agents. The other is that, I think there have been, small studies done on CoQ10, and there's never been a definitive answer that it helps. For some types of supplements, I know that they're fairly benign, and so I tell the patient, if you want to take that and that makes you better and mentally you feel better with taking that, go ahead. I think turmeric, cinnamon, these kinds of things I think are really benign, and I let them do those kinds of things. CoQ10, I think similarly, some patients find that it helps sometimes with their muscles as well, so I don't think there's any harm in taking them, but no studies have really proven that, and if they don't prove it, then it's hard for us to recommend it. Coconut oil, I would probably discourage against. Yeah.
The other one I think they mentioned was fish oil as well as fibrates, which are useful for people who have really high triglyceride profiles. So there's some patients who genetically just have very high triglycerides, which puts them at risk for some other things like pancreatitis and does increase the risk of heart disease. So for those patients who have very high triglycerides, we usually do recommend fish oil as well as potentially a fibrate, which is a different class of medication. Yeah, we can take another audience. Question over here.
Yes, for a patient with atrial fibrillation, is the reason why it's not good to take omega-3? Is there a reason there?
Yeah, omega-3 is a little bit of a blood thinner as well. So traditionally people with atrial fibrillation are already on a blood thinner, and so if you add another blood thinner to it, it can slightly increase the risk of bleeding. So we can take another question in the audience, maybe the back row. Oh, sorry. Sorry. I know. Actually, let's. I think we only have time for one more. We'll take this one quickly, and then we can take one over there.
Okay. I have a microphone, so
Sorry.
I can talk.
Yeah.
I have a quick question about the diets. They are trending now. More fat, no carbohydrate, no sugar. What is the effect of short term and long term? So much fat, encouraging everybody take is for lose weight, and doesn't matter, doesn't limit, how much meat you can have, how much, just cut the carbohydrate, and then what is the short term and long term of effect on the heart disease?
Yeah. So the question is, how does some of the trends of high fat diets affect heart disease?
Yeah. I think that diet is very complex, and you probably have seen throughout your life the pendulum swing in terms of what diet we recommend and things like that. So you guys had an excellent panel, just before us discussing the benefits of diet, and I tend to tell my patients that the diets that have shown to be most, or at least have some data to back up. Again, the data on diet is somewhat murky, but at least the best data we have is, again, Mediterranean diet, plant-based diet, vegetarian and vegan diets. Those are kind of the ones I recommend shifting towards, and minimizing the intake of unhealthy fats, saturated fats, and then substituting that with healthier fats, like from fish and olive oil, those kind of things.
Great. So let's take one question over here. I think we only have time for one more, so apologize, my back. You can take her in front. Thank you.
You mentioned sugar. Is it best to take regular sugar or artificial like saccharin, or others?
So the question is about sugar. I think the idea is that whether we can use some of these supplements for sugar. I think saccharin is generally not recommended because of other sort of synthetic things that are part of and shown increased links to cancer. So I think in general, just lower sugar the better. There are some low glycemic index supplements that can be useful for sugar, but I think in general just minimizing the sugar, but I wouldn't recommend replacing it with some of the supplements like saccharin. Stevia is one that may be okay because of how it's based, but in general I think it's just better to limit sugars in general. So we can take one more over here, I think. The man in the back.
Thank you. Last is the best. I appreciate all of you. You are the heart specialist, and this was the heart of heart session. So thank you. My question is about the stent. The one part you already did, that it has I will not call infinite life, but is a long life. So but my other question is that when you put a stent in the artery, it is a periphery. Does it attract the cholesterol deposition? Is there any studies has been done that whenever you stent, certainly at that you have expanded and the artery, but the thing is that the diameter is reduced little bit, and that at the side, if something deposits, I'm really interested in that way.
So the question is, does a stent actually create new plaque around the area of a stent? Simon?
Yeah, so I can take that one. So, in general, the best scenario for blood vessels is to not have any plaque at all. The only time we put in stents is when someone is really having an issue. So it's either a heart attack or they are having symptoms from a gradual narrowing of their heart artery. So putting a foreign body into a blood vessel is never an ideal scenario. So if it has to happen, it happens. And you definitely are still at risk for development of plaque within the stent. So you definitely have to be very aggressive with all of the other measures that we were talking about to minimize the progression of plaque within that stent. Absolutely.
Okay, I think we're out of time. We're way out of time. Thank you so much.